Good evening, everyone, and welcome to Commerce Connections. I'm your host, Catherine McQueen, and tonight we're going to be talking with Dr. Alan Jackson here at the Roseland Community Hospital. Now, previously we did an informal interview with Dr. Jackson, but right now what we're going to be doing is listening to a little bit of his educational background and experience. Dr. Jackson, can you tell us some of your experience as far as being in the medical profession and how long it's been since you've started?
Well, I have just celebrated, or will celebrate, my 20th reunion from medical school. I went to medical school at the University of California in San Francisco, and then trained at Michael Reese Hospital here in Chicago. I'm a native Chicagoan, and enjoy practicing on the South Side. My specialty is preventive cardiology, and so I try and help people not need a cardiologist.
That's great. So tell me something. Now, you say your specialty is the cardiology field. What happened previously, when you started? What did you see, in the beginning, historically, through the practice of heart medicine till now?
Well, we've seen quite a development in how we can treat people who have had heart attacks, and also the medications we can use to prevent them. So I would say that really it's the knowledge we have about certain medications, the ability to do stents, which is a way of opening up blockages of the heart without doing actual open heart surgery. I think those would be the major advances that we've seen in terms of intervention.
Okay. Now, I understand that when it comes to stents, there are certain qualities, or certain stents may last longer than other stents. Is that correct?
Yeah, there are certain stents now that we're learning. One is called a bare metal stent, the other is called a drug-eluting stent. They both are very helpful when someone's having a heart attack to kind of open it up. But then what we found is that the drug-eluting stents, you have to take your medication called Plavix for an extended amount of time. And so that's really, I think, for the layman, the real difference. The bare metal stent has a little bit of a little bit earlier closure rate if you're not aggressive with taking your medication, but you have to take that for a shorter time.
Okay. Now, you say you have to take Plavix with it, the medication. What does that do?
What it helps is that it doesn't allow platelets, which are part of our coagulation system, to accumulate in that stent and close it down. It keeps it open.
I see. And so would the diet affect the stent at all as well?
Yes, diet and smoking. So what we found is that the more vegetarian a person can be, the more of what's called Mediterranean-based diet a person can be, the more free they will be of heart disease. Smoking will close a stent no matter what you do over time, or at least increases the risk that will occur.
So what about the smoking closes the stent?
It seems to be pro-inflammatory, which triggers our immune responses in various things within the blood clotting system that seem to promote early closure.
I see. So now what about people who are substance abusers, using alcohol? Would that do anything to compromise that stent?
The major drug outside of nicotine and cigarettes that seems to affect the heart is actually cocaine.
Cocaine? Wow.
Cocaine can trigger instant cardiac death, strokes, chest pain. It's really a bad player.
I see. What about people who use the meth drug?
We're beginning to study that more. We don't see it that much in a black urban setting. I'm sure it'll come here, but it's not here yet.
I see.
We're mainly seeing the old favorites of cocaine, a little bit of heroin, sometimes both together.
Now, when it comes to stents, and then we'll move on, when it comes to stents, do you use certain ones for people of certain ages? I mean, like, say, for instance, 20 to 30, 40 to 50, or seniors, what would you use?
No, it's really not based on age. It's just what we think, or the interventionalist at the time, the guy who puts the stent in, thinks it's the best for that patient. So, for example, if a patient's unable to take Plavix, they're either going overseas and won't be able to get it,
yes,
or can't afford it, then mainly they'll go for a bare metal stent. Mm-hmm. If a patient may have surgery within a month or two, then they'll probably go with a bare metal stent. Otherwise, they prefer to use the drug-eluting stents as of now. Now, that can all change as more data comes along in the next several years. But that's the way science is. We do with what we can at this particular moment and then be ready to change as needed.
Now, let me ask you another question. As far as implanting the stent, How long does a procedure like that take?
It can take anywhere from 30 to 90 minutes.
30 to 90 minutes.
And what a stent is, it's a little tiny tube, almost like those little Chinese toys where you put a finger on each end and you can't get it open, but that's sort of the idea. They're very small. We put a catheter, like an IV tube, into someone's leg, trace it up to where the arteries of the heart are, and then through that same tube, we then trace the stent in, deploy it, looking at x-rays, okay, and fluoroscopy in particular.
Yes.
We see where that particular stent is, and then we deploy it, and we open it up, we squirt some dye, and we hopefully see a very smooth contour of that cardiac vessel.
Now, if the stent becomes damaged, how do you get it out?
It does not come out. The tissue will overgrow it.
Oh,
It
so,
never comes out.
so then if it goes bad, it's there for life?
Yes. If it goes bad, there's a couple things. If it goes real bad, then you rush them to cardiac surgery, but we really don't see a lot of that anymore. Places like Roseland, which are small community hospitals, we actually don't do them. We sort of ship them out to some of the outlying larger hospitals, but of course we take care of them afterwards. So yeah, I mean, if it goes, otherwise, you know, the body actually is quite forgiving. So often, they wind up putting one stent very near it, or diddling around. There's certain technical things they can do, but yeah, in general, thank goodness we haven't had too many bad outcomes.
Okay. Now, let me ask you, you were talking about preventive care for heart disease. What do you think are some of the ABCs of the things that people need to be doing in regards to preventive care for
Well,
hearts?
if they have high blood pressure, diabetes, cholesterol problems, they need to have that addressed by their primary care physician.
Okay.
And they need to actually take their medications as prescribed and follow up with visits. If they have a family history, they have to be more aggressive about keeping those risk factors down. You can't change your genes, but you certainly can change the environment for which those genes may become sort of manifest. So that's sort of one end. Now, in terms of exercise and diet and obesity, clearly people can take control of that. And again, I think it's just pushing away from the table, more fruits and vegetables, whole grains. The two best cooking oils are olive oil and canola oil, it turns out.
Olive oil and canola oil?
The longest lived women, actually the longest lived people, are women on the island of Okinawa, Japan. The very next group are women in France and the Mediterranean region of the world.
And is that because they use the olive oil as well?
Now, in the Far East, of course, it's not olive oil as much as raw fish and seaweed.
Yes.
But certainly in the Mediterranean countries, it's olive oil, whole grains, a lot of fish. They really don't fry their stuff. Elijah Muhammad said, eat to live, don't live to eat, and he's correct. And I think we should take that as a motto. I think one of the things that we need to think about is, soul food really developed under slavery.
I see.
And so therefore it's sort of optional. We can choose what we want out of that tradition. We can choose what we want out of a European tradition. We can choose out of a Martian one. We're beholden to nothing. And I think we have to begin to be smart in what we choose to eat and what we call our own, and actually this time make a rational decision.
I see. So do you think the people, how can I put this, eating more so in the fast food restaurants in the neighborhood? I'm seeing this like all the time. You see the fast food restaurants, I mean, just crowded with people. So.
Well, it's kind of a...
especially in our neighborhood.
Absolutely. And part of it is, look, I understand, and I do the same thing. You're rushed, you're working.
Yes.
I'll grab a burger. But really, the goal is to try and slow down and try and begin to cook one's own food, to try and eat more healthy Italian, Greek, Arabic foods. I see. That are more, again, healthy and out of that same region that seems to promote life. I always tell church audiences that, Palestine, Israel, is right on the Mediterranean also. Yes. So clearly the prophets and Jesus himself would have eaten this type of diet. So exactly. I think that there's something to learn from that. The other thing that we're beginning to study is the idea of stress, anxiety, and depression triggering heart disease, and certainly promoting behaviors that will eventually lead to heart disease. So people need to think about stressors in their life, bringing joy into their life, and a prayerful life sometimes.
A prayerful life. So they need some type of solitude.
Yes, and also camaraderie. Going out with friends, going bowling, playing cards.
So happiness and enjoyment.
Happiness and joy. I tell a lot of people who overwork that when you die, they will replace you.
That's correct.
So you have to, of course, do your job.
Yes.
But you can't let it kill you.
I see.
And heart disease will kill more Black American women and men than will AIDS.
Heart disease will kill Black American men and women
More than AIDS.
more than AIDS.
By far.
By far. Oh, wow.
And I think that we have gotten caught up into one disease, which is
see.
AIDS, and that's we should be concerned. I'm
Right,
not
because
minimizing
before,
that.
when you
But
and I...
heart disease will kill you. You have a higher chance of dying of heart disease than AIDS in the United States.
Yes. So now, let me ask you another question. What do you think about, like whole milks or anything like that, liquids contributing to, fatty buildup or plaques?
Well, anything that has excess fat will do it, whatever the source. But, once it hits your gut, the stomach doesn't really know what the source of that,
Fat
fat
is.
was. So,
Okay.
I would, but certainly in terms of dairy products, yogurt and fermented cheese seem to be better for you as a, for the human body than more raw or whole dairy products.
I see. Okay. All right then. So, and in saying that, then, what would you like to tell the viewing audience to be really aware of when it comes to heart disease?
Well, I think a couple things. One is if you get chest pain and you feel bad, you should go get evaluated. I think that's one thing I would emphasize. The other thing I would say is in terms of preventing that is to maintain an ideal body weight, exercise 30 or so minutes 6 times a week. That's the new recommendations. And again, you're not training for the U.S. judo team, so you don't need to go gung-ho. You just need to find a nice, moderate balance of what you do. And I would say to kind of live a life that is focused around the golden mean, not too much of this and not too much of that. And again, that comes out of the Mediterranean.
Yes.
The Greeks use that as their model, but they, like most things, stole it from Egypt. So it's actually an African concept. So I think that we should claim.
I see.
The moderate life.
And do you believe in the omega-3 oils as well?
I'm a big proponent of that, and again, that comes out of data from the Mediterranean region. It's not just the omega-3s. What we're trying to, there's other omega fatty acids, and they're good acids that are used for the body to do different things, different mechanisms. Omega-6s and 9s we get too much of. Omega-3s we don't get enough of.
I
so
see.
really what we're trying to, so there's no point in buying products that have omega-3, 6, and 9.
I see.
Because you're getting enough of those two.
Okay.
So what you need is more omega-3.
More omega-3.
And part of that can be lowering the omega-6, omega-9s,
All
as
right.
well as raising it. So you want the ratio to be more in balance, not just the total amount, but the ratio between the two classes of omega acids. So if you can, again, eat fish. Now the best fish in terms of omega-3s are salmon, tuna, herring, sardines, and anchovies, which we don't eat a lot of in the United States. Unfortunately, jack, cat, and buffalo are not on that list.
Okay.
Either a shrimp or lobster.
All right. And so then what about what can a person do to try to reduce their cholesterol? Because doesn't it have something to do with heart
Right.
disease?
Cholesterol is one of the major building blocks of hardening of the arteries.
I see.
Atherosclerosis. Again, prudent diet. And if you do have too high of a cholesterol, despite dietary changes, take the medication that your physician will prescribe.
Now, and what about aneurysms? Are you seeing that a lot with cardio?
Aneurysm is an outpouching of one of the vessels of the heart. It's too thin. It's almost like a balloon.
Yes.
We do see those, especially of the aorta, which is the major blood vessel of the heart. But again, many of the risk factors are the same for coronary artery disease, high blood pressure, atherosclerosis, and smoking. So if you can control those, you can control the other. As well.
Now, and then a lot of these major things that we talked about, are they only developing because of bad diet habits, or is infection attributing to some of those?
Well, there's some thought that there might be some infectious process going on with some of it. There was some data around chlamydia. That hasn't really panned out. It seems to be just the long-standing bad diet and chronic disease profile that develops in the West.
But they are looking at those,
yeah, but
those bacteria?
They are.
Yes.
But I don't think that's going to be, I mean, it may turn out to be a major player, but the point is we can slow it down no matter what it is right now. Right.
Okay, that's good. All right then, so now if a person wanted to look you up, Dr. Jackson, where could they find you?
My phone number is 312-932-0300. I have a office on the north side as well as on the south side. I'd be happy to have a consultation with you about these issues.
And so your office on the north side and south side, the address?
The north side one is 356 West Superior, and the south side address is 515 East 50th. And then when we open the office across the street at the Roseland new office building sometime in May, I'll have a suite over there as well.
Okay.
Thank you.
All right. Thank you so much, Dr. Jackson.
Thanks.
In a minute, we're going to be talking to Carolyn Jackson, and she is the director of cardiopulmonary here at Roseland Community Hospital. Good evening, everyone, and welcome back to Commerce Connections. I'm Catherine McQueen, and I'm here at Roseland Community Hospital, and we're going to be talking to Ms. Carolyn Jackson, and she is the director of cardiopulmonary. Ms. Jackson, can you tell us, how did you come to be the director of cardiopulmonary here at Roseland Community Hospital?
Well, the first thing I did was apply for the beautiful job.
All right.
That's one thing I'll say. I'm a respiratory therapist, and if you look across the nation now, most respiratory departments are merging with cardiology.
I see.
So then cardiopulmonary just goes together. I'm a registered therapist. I also have experience in cardiology, so we get a chance to do both. And they were looking for a director, and I had been a director, been a supervisor, and I wanted to come here and work. And they had a nice opportunity.
I see. So what do you find? What are you seeing more in the cardiopulmonary department now? And I can see that you're trying to do things to make advancements around here. Can you tell us a little bit what Roseland is doing?
Well, what we do is that since we're a small community hospital, we do mostly non-invasive cardiology, which means we stick with EKGs, echoes, with stress testing. We do one invasive procedure called TEE.
TEE, now explain that to
the transesophageal echo, where they look in the back at the back of the heart. In surgery, they do it in the surgical suites.
Now, what are they looking in the back of the heart for?
They want to see the function of the heart, but they want to actually put a scope down and look at it, and they watch the movement of the heart.
I see.
So Dr. Jackson and the echo techs do that in surgery. The other thing that we do in a little hospital like this, we do a ton of EKGs.
I see.
And we try to find out how the heart is beating, if there's any problems with the heart beating. And my therapist and my techs both do that.
I see.
So and we do Holter monitoring, we do telemetry monitoring, and these are 24-hour monitors that we do to check the heart to see how the patient functions in normal life.
I see. And so in that way, that's conducive with the preventive care that you give for the heart disease?
Well, it helps us with the diagnosis of what's going on. It gives the doctor an idea of what's going on with the heart at that time. And if he needs to make some recommendations beyond medication, like for exercise, if there's something that the patient needs to do about his diet that could improve his cardiac status, he also can make those recommendations. And most times he does.
I see. So by you being the head of that department, I know you can see the cases coming through here. Are you seeing more so with the seniors having heart disease that was, went undetected, or are you starting to see it more so with younger people?
We're beginning to see a nice size young population. Dr. Jackson's really been talking about that.
I see.
And we're seeing them on the pulmonary side as well as on the cardiology side.
I see.
And they're not getting enough exercise. They have a very poor diet. They're trying and experimenting with things that they shouldn't be. We see we have a drug population too. And we see 25 and 30-year-old young men, more so than young women.
Oh.
More so. And they're very heavy people with no activity.
Oh my goodness.
Active, they're not exercising, they're outside, but they're not running around the park.
So then what they need to do probably is take a lesson from the ancestors and the senior population when they used to plant gardens.
That's right.
and
That's
you
right.
know,
That's
and
right.
get out there and just, you know, go walk and get involved and do things in the
Absolutely.
community.
While they're standing on the corner, go for a walk.
I see.
You know, while they're standing.
So and then so as far as seniors, what do you see with them? Now will they take their medications like they should, or once they find out that they have a heart condition, or?
Well, what we've really found out is that once the seniors are identified as having things like congestive heart failure, some slowness of the heart, different problems with the heart, we noticed that they really do take the recommendations seriously. They are beginning to exercise more. They go to the shopping malls, they walk around, they do the things that they need to do.
I see.
Now, we do have parks in our area. We have one right up the street from us.
Yes.
And in the morning when I'm coming in, I see a lot of seniors walking.
Something to think about.
And the seniors also change their diets.
I see.
They really have done a good job over time with their diets.
I see.
They're not eating as much salt. They're eating leaner meats.
Yes.
Not as much red meat, not as much pork. They eat a lot of turkey. And I think that's important. They eat a lot of vegetables. A lot of the young people eat no vegetables at all.
Exactly, and then they stay in these restaurants as well.
And they eat a lot of fast food, which has a big sodium content, which is the salt. They don't drink as much water as the seniors drink.
I see.
So they don't cleanse themselves like they really should.
And is that important?
It's very important.
For the heart?
For the heart. Water is, to me, water is important for anything that ails you.
I see, okay. All right, so now, before we wrap this up, we want to talk about a little bit about the new center you're going to be building. Dr. Jackson talked about a new part to the hospital addition across the street. Can you tell us a little bit about that?
Well, we have on the medical center campus, and that's what we like to call it now. We started that when they did the opening. On the medical center campus, we now have a professional building. And in that professional building will be cardiology. And we'll be able to see more people. And it's a very pleasant surrounding in the building. Everything is brand new.
I see.
Everything is brand new. And we're trying to encourage as many services as we can to come together, like nutritional service. That's one critical to heart.
Nutritional services?
Nutritional service. We really need someone to counsel people in how to eat, what to stay away from, what moderation really means.
Right.
So they're going to be there. And inside our emergency department, we will have a chest pain room.
A chest pain room?
Chest pain. When people come in with chest pain, or other type of problems that they're complaining about, just some type of heart problem, we can test them. We can, get them pull them out from the regular ED and put them in a quiet. People that have cardiac disease need to be in a quiet area.
Oh, I see.
And get them in a quiet area. Get good history and physical. Get some tests on them, and that'll be our chest pain area. So we're excited about that.
I'm excited about it.
That's new. Be totally new for Rose.
All right then. So now you're going to take us for a short tour of the cardiopulmonary department, and then we'll be talking with you later. And Ms. Jackson, I want to thank you so much for visiting us here on CommerceConnections.tv. Thank you so much.
Okay, you're welcome. Thank you.
Welcome back, everyone. I'm Catherine McQueen, and we're here in the cardiopulmonary department and physical rehab with Jonathan Gasper. And Jonathan, can you tell us a little bit what happens when you have a patient who is rehabilitating from heart disease or open heart surgery, what have you? What would they be doing on these machines?
Oh, basically, when we have patients like those, we focus more on endurance training.
I see.
And how patients can tolerate activities like how long can they tolerate a certain activity. So it's like monitoring the heart rate, the blood pressure, and all that. Initially, the exercises will be not very heavy.
I see.
It's like just enough for them to function.
I see. So in other words, in these machines, they're sitting on here and you're trying to find out what they can do and what they cannot do.
Yeah.
How well the body accepts the stress.
Oh, yeah.
Physical,
Yeah, we have
physical therapy.
Mhm.
I see.
Yeah, we have we call it a scale, exertion scale.
I see.
So if the patient, if initial phase they cannot really exert that much, then we can give them very light activities, and then progress them to a more harder ones or stressful ones.
I see.
That just enough for the heart to
To take it,
to
and,
take it, yeah.
and start trying to heal itself,
Mhm.
prepare
Yeah.
itself. All right then, okay. All right, so thank you so
Oh,
much, Jonathan.
Thank you very much.
So Jonathan, explain to us now what the nurse is doing. And your name, I'm sorry?
Champagne.
Champagne. Explain to us, Jonathan, what Champagne is doing on the machine now.
Right now, she's just ambulating, trying to walk as normal as possible, heel to toe gait pattern with a good posture.
I see.
Yeah, we always have to emphasize that one. In cases of cardiac patients, we always monitor the blood pressure, the heart rate before, during, and after exercises.
I
We also
see.
monitor the respiratory rate, and that's how we can determine how the patient tolerates the exercise.
I
If the patient is, if the exercise is too high or too high of intensity for him or her, then we have to slow it down. Just be within the target heart rate, within the heart rate that is advisable for the patient.
Okay, so this is just a way to find out again what's actually happening, the stress on the body just from walking.
Yeah.
Okay.
And we also place the patient on the bike. Those are very two light exercises. Here, the treadmill and the bike. Then we go. We move on to another phase if the patient is already tolerating this exercise.
Yes.
We move to the next level.
Okay. All right, thank you, Jonathan.
You're welcome.
Thank you. All right, we're back here in the cardiopulmonary department, and we're going to be having a test done on the echo machine. Now, Marley is going to be talking with Shelly, and Shelly is going to be testing Sheena. She came in with some chest pains. So what will we be doing here right now?
Just checking to see if there's any abnormalities with her heart, making sure no fluid, all her valves are doing good, her heart's functioning, pumping real good.
I see. And so this is what, like an ultrasound?
It's an actual ultrasound of the heart. That's exactly.
And so if we take a look at the machine now, this is the echo machine.
Yes.
And so Shelly is doing, what are we seeing here? Can you show us some things that you're actually seeing?
This is to the short. And I can go right into the mitral valve.
Now what's the mitral valve?
It's one of the valves of the left side of the heart,
Okay.
left ventricle
The
and
left ventricle.
atrium.
Okay. All right. So how does it look?
It looks good.
Looks good. So Sheena is healthy, huh?
Yes.
So far, so.
So far, so good. So can you take us to another area and let's see what's going on?
Sure.
How do you feel, Sheena?
Oh, I feel good.
Have you were feeling chest pains?
Yeah, I had a little tightness in my chest.
I see. Did it radiate up through your neck?
No, actually on my left side, just my arm.
I see.
Mhm.
Okay.
This is the aortic valve, and we can also get the tricuspid valve and the pulmonary valve on this as well. And then what we would do is run color through the pulmonary valve.
I see. And what would the color show?
Shows if she has any insufficiency or regurgitation.
Regurgitation meaning what? Something that...
A leaky valve.
I see. Okay. All right. All right then, so Marley,
Mm-hmm.
now, once this is done and you don't find anything, then what will you tell Sheena?
Well, we'll let her know that when she make an appointment to follow up with her doctor, Dr. Jackson, and if everything is normal with this test, he may recommend a stress test possibly
I see.
to see, to always rule out, nothing, to make sure everything's okay.
Okay.
About it.
All right, thank you,
You're
Marley.
welcome.
Thank you, Shelley, and thank you, Sheena, so much. Okay. Yeah, the moving around.
So what type of liquid is that? What does that do?
It
Gel.
helps. You can't just put this on there. and see it. It helps image it. It's like a
It's a sonic beam.
sonic beam, right?
Now, Ms. Jackson, Carolyn, in addition to the echo machine, what other machines do you have that will you be able to take an in-depth look at the heart?
Well, we have one that's non-invasive, and that's our stress machine, where we do our stress testing. And then we have one that's invasive, where you can look inside the heart. We have a 64-slice CT scanner.
I see.
And that it has a vascular part that can really tell you whether there's any plaque or any calcium deposits inside the heart. And we would know what to treat. It's like a non-invasive scan.
I see. So
It
you
is
have
beautiful.
that right here in the neighborhood. That
Have
is
it right in
great.
the neighborhood.
All right.
Yeah.
All right. Thank you, everyone. This has been
Thank
informative to the
Thank you.
community.
Yes.
And thank you so much for your wonderful help, especially in heart disease.
Thank you.